Neurology Quiz number 79. Describe the FDA-approved non-invasive neuromodulation devices for treatment of migraine. External trigeminal nerve stimulation, the transcutaneous supraorbital neurostimulator or Cefaly device, which is now in its second generation, is used for external trigeminal nerve stimulation. Transcutaneous nerve stimulation is delivered with the device over the forehead, designed to stimulate the supratrochlear and supraorbital nerves. For acute migraine treatment, 60 minutes of treatment given within 3 hours of onset resulted in more than 50% reduction in pain after 1 and 2 hours. 24 hours after intervention, only 34% of patients used rescue medications. For migraine preventive treatment, 20 minutes of active stimulation daily for 3 months is recommended. Such treatment was shown to reduce the number of headaches by 50% in 38% of patients versus 12% in patients given sham stimulation. This picture shows the Cefaly device. There are magnetic contacts at the back of the device. The device is charged before use. An adhesive electrode is then placed over the forehead. The device is then attached to the electrode. The last step is to choose the program setting: acute for abortive treatment and prevent for prophylactic treatment. Common side effects include intolerance due to paresthesias and sleep-wake disturbances. However, no significant side effects have been reported. It is FDA approved for acute and preventive treatment of migraine in adults 18 years or older. Mechanism of action: it is postulated that convergence of somatic afferents from the trigeminal nerve branches with visceral trigeminal-vascular afferents on the spinal trigeminal nucleus nociceptors may block ascending impulses in the pain pathway. It is the only device available without a prescription. Non-invasive vagus nerve stimulation. A non-invasive vagus nerve stimulator device called Gammacore is made by Electrocore. It is FDA approved for acute and preventive treatment of migraine and for acute treatment of cluster headache in adults, as well as for adjunctive preventive treatment of cluster headache in adults. For treatment of an acute migraine attack, 2 2-minute stimulations are given on the same side of the neck. Treatment is repeated if pain persists. The device does not deliver more than 30 stimulations in a 24-hour period. For migraine prophylaxis, 2 2-minute stimulations on the same side of the neck are given in the morning and at night every day. This picture shows the Gammacore device. The patient locates the arterial pulse in the neck as the vagus nerve passes through this area. Gel is applied to the stimulator. The stimulator is placed vertically over the right location. The top button is held down until the patient feels a tingling or vibrating sensation. The right intensity level has been reached when the patient feels a strong tingling sensation or a downward pull on the lip. Gammacore beeps twice at the end of the stimulation period. This graphic shows the non-invasive VNS treatment plan for abortive treatment and for prophylactic treatment. In one open-label study for acute self-treatment of migraine with non-invasive vagus nerve stimulation, 65% of people with frequent episodic migraine and chronic migraine had pain relief within 2 hours, and 40% of the responders had freedom from pain. In another sham-controlled study of 250 patients with episodic migraine, vagus nerve stimulation was superior to sham for acute treatment at 30 and 60 minutes after onset. In clinical studies, side effects were minimal. Typical adverse effects included lip or face pulling or twitching, dizziness, neck pain, burning, and soreness. Mechanism of action: this is unclear. The input from the vagus nerve is thought to act on central pain centers via the nucleus of the tractus solitarius. Transcranial magnetic stimulation. Single pulse transcranial magnetic stimulation has been demonstrated to be effective for both abortive and prophylactic treatment of migraine. Data suggests that it is especially effective for migraine with aura. handheld device for TMS, such as the SAVI Dual, is FDA approved for acute and preventive migraine treatment. In one study of TMS for acute treatment, freedom from pain at 2 hours was noted in 39% of patients as compared to 22% with sham stimulation. Active stimulation was also noted to provide greater freedom from pain at 24 hours, 29% versus 16%, and 48 hours, 27% versus 13% as compared to sham stimulation. For abortive treatment, 3 pulses are given up to 3 times during any attack. Another study involved patients with episodic migraine and chronic migraine with and without aura who used TMS over 3 months. The preventive protocol consists of 4 pulses twice a day. It reduced the number of headaches by 3 days a month, and 46% of the patients reported decreased headache intensity and decreased use of abortive medications. This slide shows the TMS device. The first step is to power it on. The second step is to position the device as shown, and the third step is to press the treatment button to deliver the stimulation. Typical side effects include tingling, tinnitus, lightheadedness, but no serious adverse effects are reported. Contraindications to transcranial magnetic stimulation include cardiac pacemakers and metallic implants. Mechanism of action: this is thought to involve disruption of cortical spreading depression and modulation of ophthalmic pain circuit activity via downregulation of thalamocortical neurons. Peripheral electric stimulation, or PES. In PES, electrodes are placed on the upper arm and generate a non-painful electrical stimulus. A non-invasive PES device, or Nerivio, is available and is FDA approved for both acute and prophylactic treatment of migraine. The device has to be connected to a smartphone to deliver the electrical stimulation. For abortive treatment of an acute migraine attack, it is used as often as needed for 45 minutes. For migraine prophylaxis, it is used every other day for 45 minutes. This graphic shows the device. There are adhesive pads at the back of the device. There is an arm strap to keep the device in place, and the other figure shows the smartphone app used to deliver stimulation. The device is attached to the arm, then the strap is placed over the device to keep it in place. Stimulation is started through the app, and the stimulation intensity is adjusted by using the minus and plus signs. This graphic shows the treatment plan for prophylaxis and abortive treatment. In one randomized sham-controlled study, 64% of participants who had 20 minutes of PES soon after the onset of migraine attack had at least 50% pain reduction in more than 50% of their treated attacks, compared with 26% of patients who received only sham stimulation. No serious adverse effects have been reported in the trials. Mechanism of action: it is thought to exert a generalized analgesic effect through conditioned pain modulation via activation of inhibitory pain pathways. Conclusion: neuromodulation devices are an attractive alternative for patients with migraine, although the use is not widespread. Good candidates for such treatment include patients not responding to migraine medications, those with medical contraindications to migraine medications, patients unable to tolerate migraine medications, and patients concerned about medication overuse headache. More widespread use has been limited by high cost and lack of payment from third-party payers, but this is changing. Non-invasive neuromodulation devices have the potential to fundamentally change the therapeutic approach to migraine treatment, and neuromodulation could be considered as a first-line option in the future.